Bowel endometriosis is a quite a common condition when it comes to hospitals like Chelsea, where we are a tertiary referral hospital. We know that about 20% of women suffer with endometriosis, and out of that 20%, about 2 to 3% of that category where they will have bowel endometriosis, and within that they will suffer with severe rectovaginal disease, which means disease which is affecting the back of the vagina and going into the rectum and bowel. And this problem can really increase in its intensity, causing a number of issues. I will just start with very simple themes and then we build on them towards bowel endometriosis. What is bowel endometriosis? We know that there are so many theories about it. We're still learning about it, what it is, even though such a long time we have been dealing with this disease. The most common way we think that the endometrium lining, these endometrium cells, implant comes out through the fallopian tube into the abdominal cavity, peritoneal cavity, and they implant themselves into different structures like bowel, bladder, peritoneum, ovaries, fallopian tubes, and even other structures as well. And wherever they implant, they cause adhesions and scarring, leading to pelvic pain. But there are so many other ways as well to look at it. And this picture clearly shows you that the lining of the womb breaks down and the endometrial cells comes in. The back of the vagina and rectum is just a very natural place for these cells to gravitate to. That's where they come in and settle down, and obviously on top of the rectum, they start to go inside the rectal cell. And this picture will give you more idea. The rectum is just sitting next to the cervix and the uterus. So if anything is growing outside the uterus, the very natural place to grow is next to it is bowel, and hence it becomes such a common issue. Now we know that along with the implantation theory, we also know that we talk about metaplasia, we talk about maybe it goes into different parts of the body through blood and lymphatic system. We also think that there could be other way as well, that we have stem cells in the pouch of Douglas, in the area behind the uterus and between the rectum, and the cells start to differentiate, start to change into endometriotic cells and lead to these kind of adhesions. And obviously nowadays, more and more, we're talking about immunological factor, and maybe that's the thing where the future diagnosis and treatment will come from. So in brief, there are so many ways that we can explain why endometriosis grows, and then obviously involve the bowel. When it comes to bowel endometriosis, patient can present with a variety of symptoms. It can range from abdominal discomfort and pain to nausea, bloating and gas, severe intestinal cramps and pain, pelvic pain during sexual intercourse, constipation and diarrhea becomes a common symptom, alternating bowel symptoms is a big issue, painful bowel movements, rectal pain. So really it's a range of bowel symptoms which people will present. And that's actually brings a challenge. The challenge is that so many people will have these generalized bowel symptoms, but who is the one who actually have endometriosis? We know that endometriosis overlaps with so many other diseases. And if I want to pick up a common one, irritable bowel syndrome. So much has been written and searched about it, that how we can differentiate between irritable bowel syndrome and endometriosis, because most common theme is that when we go to our GPs, we go to our initial contact, I will talk around about it, then the most things comes in, maybe it's irritable bowel I have because I'm suffering with constipation, suffering with diarrhea. But then again, who are those people who actually have endometriosis? And I will come to that question. But picking the right one is the challenge for all of us to get it. When we look at other causes of pelvic pain, this bowel pain, then irritable bowel syndrome, appendicitis, colitis, colon cancer, Crohn's, inflammatory bowel disease, all these things will come in the differential diagnosis, which doctors have to look at and differentiate that. When someone has these symptoms, bowel symptoms, then what they should do? The very simple thing is they will obviously see the GP for help. But I will tell everyone listening that keep a diary of your symptoms. Your diary is the key to help us to get to the diagnosis. We have a two-way job. We have to tell our doctors, and when I say doctors, all specialties from GP to surgeons to other specialties as well, that when someone comes with these kind of symptoms where you think about other bowel problem, do think about endometriosis as well. So keep a diary. It is really helpful for us. And obviously, once you see your GP, and we'll expect your GP to do a referral to hospital to an endometriosis specialist. And we all know that it is not an easy thing. The one study from Surrey showed us it takes on average 7 to 9 years from a GP to get to a tertiary hospital to be seen by a specialist endometriosis. This is very difficult, but that's where all the education, all the efforts by organizations like Endometriosis UK come in really to help with this journey to make it shorter. And at the early stage, dietary modification may have their role as well in these things. The only differential I will try to bring in before moving on to next stage is irritable bowel and endometriosis, because there is so much overlap between these two things. And I'm sure when Ollie speaks about it, he will tell us more about it. But irritable bowel syndrome is mostly affects the large bowel. Bloating, constipation, diarrhea, cramping, pain are common thing. But the one thing will be there, this is acyclical in nature. There'll be no pattern with periods. Having said that, we also know in some, about 20% of the patient, there will be overlap. They will be cyclical as well. They will say, when my period comes, my irritable bowel symptom like bloating pain gets worse. But mostly it will be acyclical, especially in the early stages. Straining, urgency, incomplete evacuation, mucus in the stool, all those things are mostly denoted to irritable bowel syndrome. When it comes to endometriosis and how to differentiate it, then mostly endometriosis symptoms are predominant with cyclical symptoms. My pain comes when I have my period. And I was just talking to a patient a few days ago. She told me that her pains were so bad that when her periods will be coming, she will stop eating, because she will be worried that if she eats, then she won't be able to pass stool because it's so painful. And she kept going to doctors. And the only diagnosis she had until the age of 30, irritable bowel syndrome, until someone put a sigmoidoscope, and saw the lesion coming through the bowel and diagnosed it as rectovaginal endometriosis. So it can be really difficult. So cyclical symptoms are a key to endometriosis. You can make it sharp pain when you are evacuating the bowel. Painful intercourse can be a symptom. Pain passing stools and sharp pain while passing stools can be a symptom as well. And when the stools are evacuated, the pain gets better. So these kind of symptoms help us through your symptom diary to possibly come to the diagnosis early on. When someone has these symptoms, then the natural thing is that we investigate. Now, our investigation in hospital include, number one, an examination by an expert in gynecology. Vaginal examination, rectal examination. Bowel endometriosis is one of those that if it's advanced, it can be palpated. With a finger, we can palpate. There is a nodule there through the rectum or through the vagina, which is palpable. And as you touch it with your finger, someone says, oh, it's very severely painful. So we just know that's possibly the nodule which is palpable, which is so painful. Ultrasound scans are absolutely very important, and their sensitivity, their importance is increasing now because they're becoming better and better in diagnosing rectovaginal endometriosis, or in commas, bowel endometriosis we're talking about. MRI scan is a very common tool and very sensitive as well to diagnose bowel endometriosis, and especially the nodular lesions. Sigmoidoscopy, once we see them, they go to colorectal surgeon in a multidisciplinary care, and sigmoidoscopy is the one as well. However, the challenge in sigmoidoscopy is that this endometriotic nodule, which grows from the uterus through the outer bowel wall into the lumen of the rectum, it kind of doesn't penetrate through the mucosa in most of the cases. In many cases it do, but in most cases it does not. So it will involve the bowel, it will involve the muscularis, the muscle tissue of the bowel, but it will not penetrate through the bowel. So if I'm putting through the camera, I may not be able to see it. So that seeing it through the camera, sigmoidoscopy, or colonoscopy does not rule out endometriosis as such, because we may still have it, and where MRI scan and our examination will help us. And the main thing that we are all focusing now is multidisciplinary care. That's the key. That's the key for the safe and better care that I speak to Oliver. Oliver speaks to me. We speak to urologists. We speak to pain specialists. And when everyone talks together, we come up with a better solution while we have these investigations in front of us and a better management plan. When it comes to treatment, and the few slides I will show you, one is a holistic approach, medical treatment and surgical treatment. But whatever treatment we do, the principle of that treatment for us is when somebody we see, and again, you go there as a patient as well, that our theme should be that you are at the center of care. 1. 2, whatever we do, patient's expectation and goals must be the key of that management. And we should treat the patient, not the disease. That's very important. I'll come to it why I'm saying that we should treat the person in front of us, not the disease, but we are trying to deal with it. And when we're dealing with women, we should think about fertility, quality of life, psychological implication. Obviously, there's no time to go into it, but no day goes by when I see people with a huge psychological stress, what they've gone through from their very young age to the age when they get to somebody to have the treatment. And then what are the coping mechanisms? Yes, surgery is one of the tools. Yes, hormonal treatment is one of the tools. But dealing with the pain, dealing with stress and anxiety is far bigger than these things. These can be the tools to achieve that objective, but that objective may need much more things from clinical behavioral therapy, how to manage pain and how to manage anxiety and stress. And when we are seeing the endometriosis patients and surgical patients, the one thing I tell all my colleagues and our trainees that we are dealing with younger generation, young patients, mostly in 20s and 30s. Fertility is, most of the time, is on their mind. It's a benign surgery. It's not a cancer where I just say, cut it out, do this, it'll sort it out. No, it's a benign surgery. We need to be very careful. This surgery is associated with complication, which will come to the discussion, which we'll do in the next few minutes now. And the other principle will be that whatever the disease it is, bowel endometriosis, we have to be radical towards that, but conservative towards its function. Very important. We should not do anything. We should affect the function of bowel, bladder, fertility, all those things. So it has to be very conservative and to respect the patient needs what they need. And these are the principles we should underlie no matter what treatment approach we take. But that should be guiding all the doctors when we are talking to our patients. In holistic approach, I think the questions will come. It's a diet, exercise, clinical behavioral therapy, pain support. All these things do matter. Every single part of that do matter. The disease we deal with, we understand some of its pathophysiology and some we don't. We're still looking into, researching into it. So all those good practice things will come in detail later. We should be using these tools to help the symptoms. When it comes to medical treatment, it depends on patient choices. It depends if someone is trying to get pregnant or not trying to get pregnant. Our pain and quality of life is the main issue. That helps us to make the decision. Hormonal treatment, all of them are fine. There's a combined contraceptive pill. There are GnRH analogs like Zoladex. There are progesterone-only pill. So there are so many hormonal treatment. But our job is to sit with someone and to take through every single option, side effects, implications, and make a plan of care. But hormonal treatments are effective. That's the message. Hormonal treatments are effective. And there are some non-hormonal treatment as well. Again, we'll come down to laxatives or other treatment, which can help the bowel symptoms as well. Hormonal options are also good because it will treat all sides of the disease simultaneously wherever it is. It is ancillary benefit. It's a birth control as well. Generally well tolerated, relatively low side effects. Avoid the risks associated with surgery. Can be used in women who still have symptoms after surgery. It's quicker to access than surgery, especially long waiting time. I know how difficult it has been through the COVID time for the last 2 years now. Treatments have been delayed. People have been waiting for weeks, months, and maybe 2 years now to have this surgery done. So medical treatment is one tool to get through this difficult time while someone gets their surgery. And then it comes to surgical option, and I will list surgical options only to talk about it. But it depends on, again, multiple factors and all those principles I laid out in my previous slides. And it's a multidisciplinary approach. I absolutely believe in it. There is, if someone says, I can do the bowel and I can do the bladder and I can do this, I will be very careful. I would like my colleagues to be with me who are doing nothing but bowel surgery every day. And if they're next to me, I feel very good. I feel very good for the patient because I know this patient will get the best care from the best hands. And there are so many ways to do surgical options. It's a shaving, it's disc, it's resection, but I will leave it again to Oliver to talk about them. And also, I'm sure the questions will come and we'll come to those answers. Thank you very much. If someone has a bowel surgery, and if a repeat surgery is one of that landmark we can say is there to tell us if the recurrence happening, then we have never operated again on a patient where we have done the bowel operation. Having said that, patients will have some degree of symptoms. Endometriosis is a complex disease where it's involved the bowel, it involves other structures around, and there is a degree of adenomyosis in these patients as well. So some degree of symptoms will be there. And I always tell them, look, doctors can treat the visible disease. There'll be some degree of pain, anxiety, stress will be, which will be again dealt with a number of other things like hormonal treatments. And as we deal with young people, they go on to get pregnant, families and everything. So mostly these symptoms are very well controlled. Endometriosis, when it grows outside the uterus, by those different theories I talked about, it can literally go anywhere. There's no linkage between bowel and bladder. But one thing we can say possibly that if someone has bowel endometriosis, which is a severe degree of endometriosis, then it's possible that this patient actually may be involving bladder as well. But the one thing which possibly that person may be thinking about, that we know that we have kidneys and the small tubes, ureter, come all the way from the back into the bladder. They actually pass very close to the rectum. And as the endometriosis grows into the rectal area, it pulls the ureter inside. So it's absolutely almost every single complex case we do, I need to have a camera inside the bladder, and I need to put a catheters inside the ureters to make sure that during surgery we do not cause any injury to ureter. And actually part of our process of surgery is to separate the ureters from the rectum so we can do safe surgery on the bowel. So bladder itself, but ureters are very closely linked with rectovaginal endometriosis. Endometriosis is a chronically, continuously evolving disease, spreading disease. We want to stop that process of continuous growth before they come for surgery. Most people who have bowel endometriosis, they also have endometriosis in the ovaries as well. Almost 80% of these patients who have bowel endometriosis have endometriosis in the ovaries as well. But GnRH analogs too, these injections like Zoladex, triptorelin, Prostep, and even combined contraceptive pill, they suppress the estrogen. And when the estrogen is suppressed, it stops or suppresses the glandular growth, the glands of endometriosis growth in the ovary, in the tissue. So everything, in a very simpler, milder word, it calms down everything. The things become easier for us to operate, less blood flow toward the structure. So when we are dissecting in those planes, when we are cutting through those planes, which actually have no normal anatomy anymore because of the fibrosis and scarring of endometriosis, this estrogen suppression by GnRH analog injection actually helps to reduce the blood flow and makes our surgery less invasive and less bleeding as well. Common symptoms we get with bowel endometriosis are quite advanced, but it's possible, absolutely. Then there's again the overlap of irritable bowel syndrome and other bowel symptom with endometriosis, and these will be milder symptoms. People coming to us and will improve with simple treatment, what just Ollie has mentioned. So yes, people can come in with generalized bowel symptoms and help with all those things which Ollie had just mentioned from the diet perspective and laxative perspective, and that's all what they will need. But they need a proper examination, investigation to rule that out, and then we go back to simple things. Yeah, MGT is absolutely the central part of endometriosis care now in UK, since British Society of Gynecological Endoscopy started that in UK and made it a part and parcel of any center who does tertiary level care for endometriosis. MGT simply means that as the disease goes by, it goes into bladder, into rectum, into ovaries and fallopian tubes, and even organs like diaphragm and eyes. Because so many systems are involved and so extensively, it's not possible for one specialist to be able to manage all those various aspects, not only to, and even to make the correct decision, including fertility. For example, our multidisciplinary team has a fertility specialist who tells us, okay, this cyst is that big, she's that old, she wants to have children, and our next step should be to do a fertility treatment instead of an operation. So multidisciplinary team brings all the expertise together around the one table and makes the right decision for the patient. So it's like a central point for us. We do ask this question very frequently when we are examining them and investigating them. And it happens sometimes that patient has mild symptom came in with, When we examined them and scanned them on MRI scan, we found they have a recto-vaginal endometriosis, bowel endometriosis, while symptom mild. Again, we came back to the drawing board, consenting, we explained the patient. Now, there are patients who have decided after all the discussion, they will leave the disease as it is, and they will carry on until the symptom get worse. They will come back. Will disease progress? In my experience, yes, it will progress. The disease I see today with the big nodule going through the bowel obviously started to grow at some stage few years down the line, few years before. So there is an element of progression. If I leave a disease today, it will get worse. But again, it comes down to that discussion and consent process we have to do with the patient. It's mostly estrogen dependent disease in the beginning to start with. Estrogen is the one which grows the endometrial like glands around the rectum, around the bowel, and it leads to then fibrosis, scarring, and all the symptoms we're talking about. As people go towards the menopause, these symptoms tend to get better because either the estrogen deficient state. So I will say if patients have less symptom, then symptom eventually will get better, gradually will get better, and they will not need any much complex surgery if the symptoms are mild to start with. So answer is yes, symptoms should get better with menopause.